Thank you. Thank you all for joining us for today's webinar. We will be hearing from Dr. Vijaya Kancharla about the Birth Defects Research and Prevention Society's position statement on the surveillance for and the prevalence of neural tube defects. This statement from the fall of 2018 can be accessed via the BDRP website. Dr. Kancharla, as a co-author, will provide an overview regarding the Society's position on this topic, some of the methodological considerations that must be incorporated into a surveillance program, and how to best standardize and improve global surveillance efforts for neural tube defects. Dr. Kancharla is a research assistant professor in the Department of Epidemiology at Emory University Rollins School of Public Health and an epidemiologist at the University Center for Spina Bifida Prevention. Dr. Kancharla received her doctoral degree in epidemiology from the University of Iowa and completed postdoctoral training at the National Center on Birth Defects and Developmental Disabilities at the U.S. Centers for Disease Control and Prevention. She serves on various national and international research committees examining neural tube defects epidemiology and global prevention strategies. Immediately after Dr. Kancharla's presentation, we will have a Q&A period. If you have questions, please feel free to post them during the presentation via the questions panel. The question submission box can be found at the bottom right of your screen. Dr. Kancharla, thank you for joining us today.
Thank you, Amy. Greetings, everyone from Atlanta. Thank you for joining me and your interest in this webinar. In the next 40 minutes, I'll share with you about the Teratology Society position statement on surveillance and prevalence estimation of neural tube defects. Let me begin by giving you a quick background on what prompted this work. I am a birth defects epidemiologist. My work focuses on global prevention of neural tube defects. So a prevention effort is typically informed by a robust surveillance system, which is capable of capturing all cases of a given condition. In my work, I have seen time and again that the prevention of neural tube defects in developing countries is negatively impacted by a lack of good surveillance system and incomplete assessment of what the actual prevalence of these birth defects can be. So this has impacted how policymakers approach the issue of prevention and care, many a times stating that they either do not have the problem of neural tube defects in their community or that it is not a high enough problem of concern. So this challenge has strongly driven me and several colleagues from the society who have faced a similar situation to draft and publish this position statement. The statement was published in fall of 2018, where the society acknowledged the value of accurate measurement of total prevalence of neural tube defects in the population to support prevention and advocate for rigorous surveillance of these birth defects worldwide. This position statement was drafted in collaboration with society members, including Dr. Susan Carmichael, Dr. Marcia Feldkamp, and Dr. R.J. Berry, who all bring their years of expertise in birth defect surveillance and its implications, both nationally and internationally. It was an honor to be a part of this team. None of the authors of this position statement have conflicts of interest to disclose. So I'll start by a general definition of birth defects. This is according to the World Health Organization. Birth defects, also known as congenital disorders, can be defined as structural or functional abnormalities, including metabolic disorders, which are present from birth. So here in this image of a pregnancy calendar showing stages of embryonic and fetal development by gestational week, you can see that most birth defects form between the 3rd and 8th week of gestation. And these include neural tube defects, heart defects, and clefts, which are all major birth defects. So we will focus on neural tube defects for this presentation, which I will refer to henceforth as NTDs. NTDs, we all know, are major structural birth defects. There are different types of NTDs. Phenotypically, you can see anencephaly, spina bifida, and encephalocele here, which are the most common ones. And majority of NTDs are preventable through folic acid, a B vitamin, which the mother needs to take before and during early pregnancy, a time when the neural tube closes. So a critical piece of information about NTDs is that they occur very early in pregnancy, by 4th week of gestation. The problem here is that most pregnancies are not yet diagnosed at this time. NTDs in a global context, pregnancies worldwide are affected by NTDs. It is a global phenomenon, and they are, again, the second most common type of birth defects after congenital heart defects. There is a disparity in their prevalence. We know that developing countries bear maximum brunt of these birth defects, where modeled estimates show that developing countries have about 10 times higher prevalence of NTDs compared to developed countries. And these developed countries also have effective intervention strategies such as food fortification. So why should we be concerned about NTDs? They are of a significant public health concern. They are associated with high costs, have serious health implications. So there are definitely economic, psychological, and social consequences to these birth defects. They are associated with high medical care costs, which most families in developing countries cannot afford. Additionally, most developing countries do not have adequate surgical or clinical care to meet the needs of these cases. Lastly, we know that NTDs contribute to stillbirths, to elective terminations, and both neonatal and child mortality, especially under 5 mortality. So Blanco and colleagues recently published an evidence-based modeled estimate of the global prevalence of NTDs using births from 2015. So I stress here that this is a modeled estimate, and I'll tell you why we had to rely on modeled estimates. So in this study, it was estimated that there are about 2 neural tube defect affected pregnancies out of every 1,000 live births. Roughly, this is about 260,000 affected pregnancies worldwide annually. Of those 260,000 pregnancies, about 50% result in stillbirths, or they are electively terminated after they have a prenatal diagnosis for the fetal anomaly. And of those babies that are born alive, which is around 130,000 with NTDs, 75% of them die before they reach age 5 years. And again, a disclaimer that was published in this paper is that these are underestimates because the models used conservative assumptions. So we will have to keep that in mind, that these numbers are conservative. One of the statements in the conclusion of this systematic review is worthy of note. So this systematic review of all surveillance systems worldwide by Blanco stressed that there is a paucity of high quality surveillance data in the regions of the world where we expect the highest burden of NTDs. So both the lack of surveillance and incomplete assessment of affected pregnancies make NTDs invisible to policymakers. I want to put the spotlight here on the prevention of NTDs for a second. As I mentioned earlier, the majority of NTDs are preventable with folic acid. There are other causes for NTDs, but the most common is deficiency of folic acid in maternal diet before and during early pregnancy. So in the early 1990s, randomized trials unequivocally showed that folic acid prevented up to 70% of both recurrent and first occurrences of spina bifida and anencephaly. So that is something to keep in mind, that there is strong evidence for prevention. And since 1990s, or late 1990s, over 60 countries have implemented policies that mandate folic acid fortification of wheat and maize flour. And right now, there are efforts to also fortify rice, which is being done in some countries. But wheat and maize flour are fortified in many countries, and it is done as per the recommendation of the WHO. So this intervention has led to a reduction in the number of cases of neural tube defects worldwide in the last 20 years. So every 2 years, the Center for Spina Bifida Prevention at Emory University, where I work, we model the status of global prevention of neural tube defects through mandatory fortification of wheat and maize flour. So the latest published estimate is for year 2017 that you see here on the map. The countries that are colored in green have high prevention because they have adequate fortification. And some countries which are in a spotted yellow in West Africa have moderate prevention because the folic acid added is not adequate enough to reach the full potential for prevention. But what is jarring here is most countries still do not have any prevention, which is majority of Africa and Asia, Southeast Asian regions. So overall, when we calculated the proportion of prevention that's been achieved in 2017 through fortification is only 18% of all preventable cases that we are able to prevent. So there is still a lot of potential for other countries to implement interventions to reach close to 100% prevention of folic acid preventable neural tube defects. So you may think, what is stopping these countries from implementing fortification or prevention policies? One of the most common challenges is lack of political will. So policymakers in developing countries do not have good surveillance data showing the burden of NTDs. Other challenges for fortification are related to what people eat, centralized milling capacity, and geographic factors, which can limit the reach of fortified foods within a country. So with that background on folic acid and interventions associated with folic acid, I will bring us back to the surveillance of NTDs, which is the focus of this webinar. So counting the total cases of NTDs and not just those that are visible is crucial to our understanding of their occurrence and prevention. So I want to stress on the definition of public health surveillance. So a public health surveillance is defined as the ongoing systematic collection, analysis, and interpretation of health data for public health purposes, and the timely dissemination of public health information for assessment and public health response to reduce morbidity and mortality. So every attribute of this definition strongly applies to NTD surveillance. One of our major goals is to avert preventable cases of NTDs and prevent mortality associated with these cases. Surveillance helps us in advocacy for primary prevention of NTDs and to plan services for those living with these conditions. Surveillance, as we know, is a cornerstone to evaluate how effectively folic acid interventions are working. Birth defect surveillance helps in many activities related to research, prevention, and to take care of those impacted by NTDs. Surveillance helps to identify disparities in prevalence, effects of prenatal screening, understand health and mortality outcomes, service planning and delivery, and to evaluate prevention programs like folic acid supplementation and fortification. But many developing countries lack surveillance systems or have systems that do not capture the complete burden of birth defects. So to help countries conduct systematic surveillance of birth defects, the WHO, Centers for Disease Control and Prevention, and the International Clearinghouse for Birth Defect Surveillance and Research, the three organizations collaboratively developed a training manual that is shown here. This training has been implemented both in person and online since 2014. The training has benefited countries operating existing surveillance systems as well as those that want to set up new systems. The training manual provides countries, especially in resource-poor settings, a logic model on how to conduct surveillance for birth defects. The logic model goes through steps needed for identifying resources, what activities to plan, the outputs, both short-term and long-term, guiding registries to systematically establish a functional and sustainable surveillance system. This manual has a comprehensive list of surveillance approaches, and I just highlight a few, including what is the population that we need to target for surveillance, case determination, right inclusion and exclusion criteria, what pregnancy outcomes to include, what type of diagnostic coding to use, data management, and collection and other relevant methods and tools that are needed for a robust surveillance. We all can agree that an important attribute of birth defect surveillance system is achieving case specificity. Coding for birth defects can be complex. So the coding section of the surveillance training manual provides guidance on diagnostic coding scheme. And what this does is it standardizes the coding process across registries, which allows for consistency and comparability between registries. So pregnancies affected by NTDs can result in different outcomes. So showing here, you can have early spontaneous abortions because of NTDs, which may be a bit hard to capture, but stillbirths are a common phenomenon with NTDs. Elective terminations, again, in countries which have policies for elective terminations, and live births. So all of these pregnancy outcomes should be counted to get a total and accurate prevalence estimate of NTDs. But most countries do not have the capacity to capture non-live birth outcomes affected by NTDs, and that results in an underestimate of their total burden. So let us look at what pregnancy outcomes would one need to capture to count all NTDs in the population. As you can see in this image, systems that capture only live births tell just a partial story. So that is just the tip of the iceberg. There are many prevalence estimates reported in the literature. So it is important to note what birth outcomes are included in the numerator and denominator of these prevalence formulas. Our goal should be to capture total prevalence, which includes live births, stillbirths, and elective terminations. We would have a near complete picture of the prevalence of NTDs in the population using total prevalence formula. Most developing countries without a robust surveillance system may only capture live births, thus missing a large proportion of non-live born NTD pregnancies. That is a problem that we cannot ignore, and we all have to work on it. Here is an example. The EuroCat system shows that by counting only live births with NTDs, we miss 80% of cases that end in either stillbirths or elective terminations within most European birth defects registries. The situation in the US. So in the US, we have a long-running state-based surveillance systems network that tracks NTDs, and that has allowed us to look at the prevalence trends before, during, and after mandatory food fortification policy with folic acid, which was implemented in the US in 1998. So the National Birth Defects Prevention Network system tracks both live and non-live births with NTDs, providing us a rather complete view of the effectiveness of fortification policy in the US. So some important characteristics of surveillance systems are that they should have active case ascertainment, use multiple data sources, have population-based case tracking. Prospective surveillance systems are preferred over retrospective ones. While we have mandatory reporting legislation, people are more likely to report birth defects with these legislations. So that is another virtue to have for a surveillance system, to have most accurate surveillance data. Here are some examples of surveillance systems, mostly in developed countries. And you can see that their coverage, the age until when birth defects are tracked, criteria for counting birth defects and stillbirths are all a little variable. So that is something to keep in mind, that surveillance systems can have variable attributes if you want to compare information between different systems. This slide by Zaganjor and colleagues from the CDC shows the lack of population-based surveillance systems in most developing countries, especially Africa and Central and Southeast Asia. And even if there is a surveillance, it is incomplete and may be tracking just live births. So what do we do when we do not have surveillance systems to inform us about the total prevalence of NTDs? There have been groups that have modeled the prevalence based on available data using assumptions that may not be completely accurate sometimes. One such example is modeled prevalence of NTD by the Institute of Health Metrics and Evaluation that publish the global burden of disease for various health outcomes. So in this, vital registrations and verbal autopsy reports are used to extrapolate NTD prevalence. You can think that how this can be a problem for developing countries where most of these countries lack good documentation of births or deaths. There's also a high prevalence of home births, which will be missed by this approach. So these modeled estimates, again, did not include stillbirths and specific NTD phenotypes, leading to a significant underestimation of total prevention of NTDs in global burden of disease studies. Another modeled estimate that's out there is published by Modell and colleagues, and this is NTD prevalence for countries globally, published in March of Dime's Global Report on Birth Defects. Modell's estimates are extrapolated from several sources, and although suffer from some precision problems, they allow general comparison of prevalence across different countries and have been helpful in advocacy efforts. In 2018, Blanco and colleagues built on Modell's methods and estimated global and country-specific prevalence of NTDs with certain assumptions and limitations. So with this background and state of science in available evidence on prevalence of NTDs, the Society for Birth Defects Prevention developed a position statement. In it, the Society recommends approaches to standardize and improve NTD prevalence estimation globally by achieving population-based surveillance using multiple data sources, standardizing data collection procedures, and including all pregnancy outcomes and all NTD phenotypes. Both isolated and multiple birth defects have to be counted, along with NTDs that get misclassified as preterm births during early neonatal period. Fortunately, we have resources to conduct robust surveillance of NTDs, and these are developed by the expert global organization group that are listed here. And in this slide, you can see the training materials include a manual for programmers, pictorial atlas of birth defects, and facilitator's guide. On the ground, technical expertise is available to interested parties through the CDC for initiating surveillance in developing countries. Another resource is that the training can be completed online in an asynchronous self-timed format. The Society's position is that partnerships are vital for surveillance, and these include local, national, and international partnerships. These partnerships help in standardizing surveillance techniques, pooling information, addressing gaps, and strengthening advocacy for birth defect research, prevention, and care. Some examples of Very successful existing partnerships include the National Birth Defects Prevention Network, which is a US-based statewide partnership of registries, the International Clearinghouse for Birth Defect Surveillance and Research, EuroCat, with European registries, and the Latin American Collaborative Study of Congenital Malformations in South America. So the position statement stresses the role of stakeholder involvement as well in running successful surveillance systems. Community involvement is particularly needed in resource-poor settings, where there are no prenatal services and where home births are common. To engage local personnel like area health extension workers, by training them and involving them would be very good to gain community trust and buy-in for surveillance to run effectively and stay sustainable. The society's position is that surveillance should ultimately inform public health action. That is the ethical aspect of a surveillance system. There is a strong consensus that inaccurate surveillance hinders prevention. We should use data from surveillance systems and avoid our reliance on modeled estimates, especially when these models are not informed by strong empiric data. So this is a huge issue in developing countries that we need to address to gain a complete understanding of global prevalence of NTVs. I wanted to list some considerations for the future. We should focus on methods to improve models like the global burden of disease, on which policymakers prefer to rely because they are easily available and they are user-friendly with their interface. But investing in proper surveillance systems has return on investment in the form of cost saved in averted morbidity, mortality, and healthcare. So the society calls for a singular effort by countries to count all NTDs, not just those that are easy to see and count. I want to bring us to the end of this talk by acknowledging the list of partners who endorsed this position statement, including the Council and Teratology Society Public Affairs Committee, Organization of Teratology Information Specialists, OTIS Mother-to-Baby Group, Developmental Neurotoxicology Society, the European Teratology Society, the National Birth Defects Prevention Network, and the Board and Scientific Committee of the European Network of Teratology Information Services. Thank you for your review and comments in the preparatory phases of this position statement and for your final endorsement. A special thanks to Susan Marcus, who played a big role in developing this position statement. Her wisdom and institutional knowledge is highly valued, and she helped us with smooth coordination with all the endorsing partners. So I will end here by quoting this statement by the recent systematic review of global NTD prevalence that I had mentioned earlier by Blanco and colleagues. So in this paper, they say that the burden of NTDs is largely hidden, with around half of all cases globally estimated ending in elective terminations or stillbirths, and these are often hidden and invisible to policymakers. We have a great responsibility to make these invisible cases visible. This is the only way to get the political will we need for prevention and care of NTDs globally, and to have strong empiric data on the actual burden of these birth defects. Thank you again for your interest in this topic, and I'm ready to answer any questions.
Thank you, Dr. Concherla, for this wonderful presentation. Again, if you have a question for our speaker, please feel free to submit it via the questions panel. Dr. Concherla, our first question is, what obstacles do you foresee in implementing this rigorous surveillance program like this globally, especially in countries, especially in the developing countries?
As I had mentioned earlier, political will is definitely a very important thing to have. And we need to make birth defects visible and for those in power to understand the importance of counting them. So funding would be one of the main obstacles, as well as knowing that there are resources out there to help countries set up surveillance system. You can start small. It doesn't have to be an extensive surveillance system at the beginning, but that is what the training manuals that I presented help countries to set up, especially in resource poor settings. So we need more awareness about the importance of birth defects at every stage, starting from the highest political stage to healthcare, and to also increase the awareness among families to advocate for these kinds of efforts.
Thank you. In your presentation, you spoke about the importance of folic acid supplementation, especially very early in the pregnancy or before getting pregnant. Do you anticipate that as more standardized surveillance programs are put in place, any new causative factors or preventative factors would be identified?
So this brings us to the concept of triple surveillance that's proposed by Dr. Berto and colleagues, where surveillance can be done to first identify the actual burden of birth defects, but you can also expand the surveillance to identifying risk factors, as in collect information from the mother as to exposures during pregnancy. That would be another extension of a good surveillance system, which happens in several developed countries. So yes, as we expand our ability to collect more data on what could be potential triggers, we would definitely understand risk factors. But as of now, I think the research on risk factors for neural tube defects is pretty good, and we have identified, along with folic acid, some other risk factors such as maternal diabetes and exposure to valproic acid, which is an anti-epileptic drug during pregnancy, increases the risk for neural tube defects. And there are some other risk factors. Again, as we collect more data and have the ability to do so, we might learn more about NTVs.
Thank you. I have another question here. There's an abbreviation used, so I'm not 100% sure what's being asked, but what is the availability of prenatal U/S in developing countries, which may influence prenatal identification of neural tube defects?
Yeah, thanks, Philip, for this question. Yes, so prenatal ultrasound plays a very important role. And again, as I showed in the European context, where there is high prevalence of prenatal care and ultrasound to diagnose NTDs early in pregnancy, which will prompt to elective termination. So that is something that we need to understand in every country context. What is the available prenatal care, as well as these kind of diagnostic tools. So in developing countries, again, that is something that we need to know in every country, the context of whether or not ultrasounds are available, and then what does that lead to. So in some countries, it is illegal to abort, whereas in some other countries, that is an option available to families. So those should be taken into account. And definitely developing countries, I know in an Indian context, this is widely used. And again, anecdotally, I've heard that once the family detects that there is a neural tube defect, they are actually kind of nudged towards going for an elective termination. So depending on, again, country income level and policies on diagnosis, the prevalence has to adjust for those attributes as well.
Great. And I just want to emphasize again, if any of the participants have a question, please feel free to submit it via the questions panel. I have one more question here. Dr. Cancherla, I was curious as these programs, surveillance programs, are being revamped and brought on board, are you observing any differences in the reported prevalence of certain neural tube defects versus others?
That's a good question. So again, surveillance systems can work on increasing their capacity. So I have personally not seen that numbers changed, but again, the goal is to have good surveillance systems from the start that are able to capture all cases without any biases. So one thing that, again, the training manual approach is to start small. So maybe you can start in a small region and then expand it or start as a hospital-based surveillance. And once you gain a perspective and see how the system is running, then you can expand it to a more population-based surveillance system. So definitely the quality of data will inform how good our estimates are. And again, surveillance systems need to strive for capturing the best data available without biases or missing cases.
Okay, great. So I see that we have some other questions here. What is the factor that most influences low prevalences in some registries?
I would say that is missing those types of outcomes I had just mentioned about. So live births are somewhat easy to capture because, again, you can see them, they're visible, but you may be missing stillbirths, you may be missing home births. Terminations, especially in countries where terminations are illegal, but families can still somehow gain access to them, those would be missed. And that could result in a fictitious number, which would tell policymakers that that is not a problem, when in reality that's opposite. So we need to know all the outcomes and how are we tracking them. Do we have full control on accessing all data sources that would inform us about all outcomes?
And another question here is, what are some new strategies that we can explore for funding surveillance, research, and education when we have budget cuts from government grants? One suggestion here or question is, how can we approach insurance companies or other partners that might bear the cost but don't have a focus necessarily on the prevention?
Oh, that's a good thought. I have not seen, in my experience, that kind of funding, but there are definitely routes to explore. Again, increasing awareness and informing those who are capable of funding about the significance of this and the return on investments are, I think, going to be good motivators for countries to take up surveillance systems. Another thing I observe is that the networks are really great in terms of motivating neighboring countries to start a surveillance system. So that's another option. But I think in order for the surveillance system to be sustainable, we need to have a buy-in from the government. So if it is an insurance company or if an organization is doing it, I am a little worried about the sustainability of it. But it's definitely potentials for various organizations to consider funding these surveillance systems.
Great. And then touching on, we mentioned before folic acid, and I think you, as far as other factors, you indicated that there might be an association with maternal diabetes. There's a question here about whether you've collected any data on the association of maternal diabetes with NTDs, as well as environmental temperature as it might relate to NTDs.
Definitely. So I have not personally collected the information, but I know the resources. So the one I talked about in the US, US has many states that are involved in active surveillance of birth defects. And piggybacking on that, the CDC has a beautiful study that can help us understand risk factors. And this study is a case control study called the National Birth Defects Prevention Study. So over 10 states participate in the study, and all these states have surveillance systems that are tracking birth defects and have cases that are confirmed. So the CDC case control study gets information on the cases from these states and select a group of control mothers from live birth records from these states, and then form this huge case control study where they reach out to the mothers and conduct a telephone interview, both case and control mothers, asking them about various factors, including their exposures, their health status, and genetic factors. So it's pretty extensive, comprehensive survey that informs us about various risk factors. And this case control study has informed us about diabetes and neural tube defects. Currently, I'm involved in a study looking at some environmental exposures and neural tube defects. So this is an example in the US, but there are studies elsewhere in other countries, smaller studies, which can link to a surveillance system. So they have the complete case list. So you're not introducing any bias in terms of selecting your cases. As long as you know and you're confident that all cases are captured by the surveillance system, you can base an etiologic study to look at risk factors like diabetes, hypertension, etc., that mothers may have to inform and use that information to understand various risk factors.
So building upon this, can you comment on the prospects for preventing these folate non-responsive NTVs in the future?
Definitely. So again, for every known potential cause, we can devise prevention targeted at those. So for folic acid, we know that mandatory food fortification is an effective method. Some countries use supplement programs where they encourage women of reproductive age to take folic acid supplement, but even in developed countries, the acceptability of that intervention is only like 30 to 40%. So that is about folic acid. But for others, like diabetes, you can have improved preconception care. So the women of reproductive age, again, preconception care is not a common term. We don't hear about it as much as prenatal care, but much needed. So having annual checkups for women of reproductive age and counseling them if they either are diagnosed with pre-pregnancy diabetes or are in the risk group, having a proactive approach in addressing and taking care of these symptoms and keeping the insulin levels under control would be one way to approach. And same with other risk factors that we know. So we actively have been working on reducing exposure to valproic acid. So the interesting thing about valproic acid, which is an anti-epileptic medication, it is a well-known teratogen at this stage, is that it's used in outside of epilepsy context. So valproic acid is also prescribed for other conditions, like I think migraine. But again, knowing what are the other routes of prescription and informing clinical care providers about the dangers of these would be another way, is again to increase education and awareness about known risk factors outside of folic acid.
Great. Your talk has generated a lot of interest and a lot of questions. I hope you don't mind a few more.
Oh, of course.
So returning to the role of folic acid, I have a question here. On the slides, you had indicated that China did not have a significant folate program. And there was a question, I thought that China actually supplemented soy sauce with folic acid. Is that currently used?
Yes, so there are various vehicles that people are considering, the most common is wheat and maize flour. Rice is now coming into market, folic acid fortified rice. We just published a paper, or it's in the process of publication, looking at salt as a potential vehicle to add folic acid along with iodine. And that has actually showed that the map I showed earlier for wheat and maize, where you have huge gaps in Africa and Asia, if we are able to fortify salt, that gap is covered because those are the countries where salt is highly penetrant. Soy sauce, there are countries, example, Costa Rica has fortified a lot of vehicles, including sugar, milk. So definitely, and there is research looking at vehicles that are commonly eaten in different countries. So wheat may work in some parts of the world, not in others. So we'll have to target our vehicles based on what's hugely consumed and easy to fortify, and the folic acid remains viable through the cooking process. So China is again a country which has helped us understand the importance of folic acid, because one of the first few studies that gave us this knowledge was done in China, where they had a huge randomized community trial with folic acid supplementation showing that folic acid helped reduce neural tube defects. So it would be great to have soy sauce fortified with folic acid and any other vehicles that might work in that country context. So I am not an expert in fortification vehicles, but our partner organization at Emory University, which is Food Fortification Initiative, ffinetwork.org, has information on fortification, country-specific profiles, what is each country fortifying with, do they meet the guidelines, etc. So that's a great resource to know.
Great. And then I have another follow-on question to that, is that here in the U.S., there was a lack of fortification of maize before 2011. And the question is there a higher incidence of NTDs among the Hispanic population in the U.S. as a result of this?
Yes, that's a great question. So maize, again, here we call it as corn masa flour. Yes, so in the US, there is a mandate to fortify wheat and other wheat flour and maize flour, but only a voluntary legislation for corn masa. So that is a problem, as again, US has a great surveillance system and you can track trends. So what we saw is after food fortification with wheat in US, the prevalence of neural tube defects has come down in whites and blacks, but we didn't see any change in Hispanics, especially Hispanics who are still not acculturated to US diets. So for the past few years, CDC, March of Dimes, and certain organizations have been working in changing this legislation from voluntary to mandatory for corn masa flour so that Hispanics benefit from this intervention. So as of now, yes, Hispanics do have a significantly higher prevalence of NTDs in the US, mainly because corn masa is not fortified. And I would like to talk about a small study we did here in Atlanta, which was published in JAMA. We went to the Hispanic markets, collected samples of various products of corn masa flour, corn tortillas, and sent them to a lab to analyze if folic acid was present in them. And this was done 6 months after FDA announced the voluntary policy for corn masa fortification. Before that, there was no policy. So we wanted to see if voluntary fortification is working, and the samples came back showing no folic acid. So maybe voluntary is a good idea, but it's not working, and we need to, again, change it along with wheat and maize to make corn masa fortification mandatory in the US. And then we would definitely see reductions in NTD prevalence in Hispanics, which currently we don't see.
So I have another question here about ultrasound. Going back to that, do you think that collecting information on NTD diagnosis by ultrasound, thus providing true numbers, is there any data on that and how that might work?
So does this mean use ultrasounds as a source for cases?
It says, is there any data on collecting NTD diagnosis by ultrasound, thus providing true numbers?
Yes, so most of the registries in developing countries, as I mentioned in the US, EuroCat, they use laboratory diagnosis as one of the forms of data sources to inform NTD. So yes, we have information where possible from ultrasound centers to collect the cases.
Great. And then I have another question here as to whether the society has a committee that continues to work on NTD and folic acid issues.
This is probably a question for Heather. So my role was in developing this position statement. specifically looking at surveillance, as I gave in the background, that a lot of times when, and my work is global prevention of NTDs, and our center tries to reach out to countries to, again, increase awareness and provide knowledge about fortification. And a lot of times what we hear back is that we don't have a problem. And that prompted why surveillance is important. And the other big reason was a lot of times policymakers are using modeled data which are not complete and are misinforming. So they may think that it is not a problem, whereas it's actually a big problem in many of these countries. So surveillance was a topic of my interest, but definitely I do understand there are various members in the society who are interested in folic acid and neural tube defects. So Amy, are there any other questions?
Oh, I'm sorry. I was speaking on mute. So one of our follow-on questions is, do you have any information on maternal seizure disorder on medicated? And is that still considered a risk factor for NTDs?
Unmedicated? Did you mean unmedicated?
Yes, so maternal seizure disorder by itself.
Who are not on valproic acid, you mean?
Yes.
Oh, okay. So again, I have not seen that in my review of literature. So valproic acid, again, is given for seizure medication, and the direct link has been made with valproic acid exposure, not with the seizure disorder itself, which is, again, like what we talk about when we think of confounding by indication. That is not what I've read so far. Another thing about valproic acid and neural tube defects, I think there are studies that looked at whether folic acid has a beneficial effect among those who are taking valproic acid and are at risk for neural tube defects. And again, these are observational studies which have found some benefit that, say, if the pregnancy is unplanned and the mother is on valproic acid, not intentionally, again, taking it because it's needed for the seizure disorder. But if the mother is also taking folic acid, that reduced the risk of neural tube defects in spite of the exposure to valproic acid to a certain extent. But by itself, seizure disorder, I have not seen evidence on their direct link.
Great, thank you. There's been a lot of interest in your talk. Thank you so much, Dr. Concherla. Very big thank you to you for speaking with us today, and also a very big thank you to all our participants on today's webinar and for the very interesting follow-on questions. Before we close, I would like to make a few announcements. First, although the Society had to cancel its plans for the in-person annual meeting, we will be having a virtual meeting which will take place from June 25th to July 2nd. This will include the continuing education courses as originally planned. In addition to some of the sessions that we already had in the works for this year's meeting, an exciting and very timely addition is a webinar on COVID-19 and pregnancy, which is slated for June 11th. This webinar will take place a little bit in advance of the other annual meeting activities and will be open to anyone. But those not registered for the annual meeting already will need to register for this event separately. So please visit the link you see at the bottom of this slide for more information on the annual meeting, and be on the lookout for an e-card announcement specific to the COVID-19 webinar. Second, we appreciate your participation in today's webinar and would really like your feedback and input on topics for future webinars and educational offerings. This is an opportunity for you to help shape our programs, so we hope to hear from you. Along these lines, we will be sending out a survey immediately after today's webinar and hope you will take the 5 minutes or so necessary to complete and return the survey to us. Thank you.
And with that,